So I know some of us have spoken about blood before, and we talk about giving blood and blood being the thing and volume being the thing that patients need, and that chimes in with the physiology. But we've got to look at what fluid and what thing we're giving them. So the next speaker is the principal investigator of the SWIFT trial and is a consultant haematologist and is going to speak to us about the blood trials and our experience in London and around the world. So hand over to Laura.
If I fall off this podium, please take a picture, but don't share it on social media. And if I do get injured, I'm in safe hands. So I'm a consultant hematologist, so I'm not a paramedic. I'm not an anesthetist, so don't ask me difficult questions. I'm just the lab person behind the doors that causes you a lot of problems. But I work for the blood service, and the other half of the time I work for the hospital. So that gives me the luxury to understand the issues that the blood service has and your problems. So trying to bring them together has been probably one of the privileges in my job. And then the 8th day of the week, I spend some time doing research. So I'll share with you the whole blood journey. This is a journey, so there will be no conclusion of the UK. How did we reach to the whole blood? And it's a journey of so many organizations, and within those organizations of so many people who have been part of it and have really guided us into the trial, which you might say may not have been the right ending, but I think it was the right way to conclude this journey. So I've called it the whole blood program. And within that, you will see there were so many projects that we had to deliver. And I will share with you the results of those projects and how they all led to the design and the running of the study of whole blood in frontline trauma called SWIFT. And it's an acronym that I came up with, which I'm very proud of. So I will fast forward the evidence because I think you all know what have been the trials in blood transfusion and in trauma. But in 2015, the proper trial was published, looking at different ratios of red cell, plasma, and platelet, with the primary outcome being 24-hour mortality and 30-day mortality. There was absolutely no difference in the primary outcomes, and the trial was underpowered. The secondary outcome showed that death from exsanguination was better in the high ratio versus the 1:1:2 ratio, although this outcome was subjective. So you could argue that even that one, I would take it with a pinch of salt. Either way, this is what the UK guidelines very quickly published. This is the British Society for Haematology guideline on management of major bleeding and the National Institute for Health and Care Excellence, that for all trauma patients who come into hospital with bleeding, we must transfuse 1:1 ratio of red cell and plasma. And if NICE issues recommendation in the UK, I don't know how much you know about our system, we are obliged to follow, and we have to show evidence that we have complied with that evidence. And in some recommendation, NICE also gives you financial incentives. So that's where you get your managers pushing you to do something because they're not getting their pound. So that was fine. So by 2016, the London Air Ambulance approached me saying, well, hold on, we are already giving blood on board to these patients. So the recommendation should apply not just to patients who come into hospital, but also to patients who present outside hospital with trauma bleeding. And that was fair and square. So I said to Anne Weaver, who approached me then, well, you can have thawed plasma. You will meet that demand. But their argument was that, thank you very much for giving us the thawed plasma, but we don't have enough space in our vehicles. We have limited IV access to those patients. Some of them may have lost a limb. So which medication or blood product are we going to give first? So you're not making it easy for us. It does mean that we need to carry many boxes with many products, which is not ideal. But the most important part, I think, for me is, and I hear that happening now, that people try to give all the component at the scene of the accident instead of pushing these patients straight to the hospital, which is the place where they will get the ultimate care. So you want to shorten that time. So London then wanted whole blood because US had already implemented it. Norway had already started using whole blood despite the lack of evidence. So this is what we realized straight away, said, ooh, okay. Within our manufacturing processes, we use leukodepletion filters, and UK was the first country to introduce that because of variant CJD, and is a safety procedure that has been taken up by many other countries, and it was a good thing to do. The problem with leukodepletion filters that we use at the moment is that they remove 80% of your platelet. So what you end up with is a whole blood without platelet, or what I'm going to call from now on, red cell and plasma in one bag. So we turn to the London and say, well, you can have this product. It will fulfill your criteria, and we have a lot of data in the UK to show that it's safe because we use it for a certain group of patients. You can use this product, you get your red cell, your plasma, and you will comply with the guidelines. But no, they wanted whole blood. So then we agreed that, fair enough, we were aware that there were filters in the market, mainly by one supplier that can spare the platelet, but we had not validated those filters. And within the blood service, we operate under very tight and high standards to demonstrate that whatever we do, any minimal changes we make to the component, we do not compromise the basic standards of the quality. So this led to the whole blood program being initiated in 2016. And I can't believe that 7 years down the line, we still have not completed the program. But it takes time to do things properly and in a robust way. The first thing we agreed we will do is you can have your RCP or the red cell and plasma in one bag. Now, you will comply with the guidelines, but we want the London Air Ambulance to work with us, with the blood service, to collect some good data to move us to the next stage. Second, we agreed that we will evaluate the new filters to produce whole blood component that can then be used for future in hospitals in the UK. And the last project was to really put all this together to look at, can we design and plan a randomized controlled trial that will compare whole blood versus standard of care in the UK. So I will share results of key parts of this program, and then I will conclude with a SWIFT trial. For the SWIFT trial, I don't have any data to share, but I will update you on where we are with regards to recruitment. So the RCP study was an observational study. The primary objective was mainly logistics. Can the blood service deliver this component to the London Air Ambulance? Was the first one. And the second one is, considering that this component will only be given to one group of patients, we wanted to see what the wastage would be in the hospital, which is very important. When people come to donate blood, and in the UK we don't pay our donors, you are responsible to make sure you do not waste that precious donation. And the secondary outcome were clinical. We wanted to look at 24-hour and 30-day mortality of the red cell and plasma component versus standard of care, and I'll come to that in the next slide. And we really wanted to assess the advantages of giving a combined product versus separate product in pre-hospital setting, which were the reasons why the London Air Ambulance came to us. But we wanted to really document those advantages. And the last part is to look at safety of the red cell and plasma, because remember, in the red cell and plasma component, you have plasma. We were going to give group O RCP. That means you have anti-A and anti-B in the plasma. So you need to make sure that you do not cause any hemolytic transfusion reaction to patients who are non-group O. So the design of the study was the London Air Ambulance. We agreed that from October 2018 to October 2020, we'll switch from giving red cell transfusion only, which was what they were doing then, to giving RCP transfusion only. And we told the service to carry on doing exactly what they've been doing before. We did not change their practice or the criteria with regards to who to give this component to. And then our comparator arms were two arms. One was a retrospective arm. This was a red cell arm in London. We have collected very good data on patients who have received red cell transfusion only in the pre-hospital setting. And this is the timeline for that retrospective data. And the blood service demanded that we also have a prospective arm. And we were very well aware that there were services, pre-hospital services, in England that were giving red cell and plasma. And we were very lucky that they approached us and said, we want to be part of it. So they are your prospective comparator arm against the red cell and plasma. So the first one is the wastage. I haven't included the other primary objective, which was, can the blood service deliver the component to the hospital? Yes, they could. So they met all the criteria that we had set. And for any study, when you start, you do need to pre-specify what are you going to look for. And for wastage, these were the traffic light criteria that we agreed with regards to this component. So if you're wasting more than 30%, then I think we can't continue like this. And then if you're wasting less than 8%, then we said this is acceptable. And we took some of these numbers based on the current blood component wastage in the trauma setting. So Josephine was one of the biomedical scientists who did a PhD in this. And here is the wastage level. Within 2 to 3 months, the wastage of this component was 70%. And I started to get so many emails from the blood service, at which point I refused to respond to them. It was very painful to really deal with that. So first, very quickly, we made a decision. We cannot continue to give this component only to pre-hospital teams. So we decided to move it to A&E patient, to trauma patients in A&E who were bleeding. And that indeed had an effect on the wastage. But with any new intervention you implement in hospitals, you're dealing with a lot of people. You need to make sure you keep training colleagues. And also you need to change the way people do. People are used to getting red cell and thawed plasma. So even though this new component was available in the fridges, they were not picking it up because they were not aware. So what we did, we used our research fellows. We got 24/7 trauma research fellows at the Royal London Hospital. So we used them to try and help us to get people to use the component in hospital. And indeed, that had the biggest impact on the wastage. But the wastage was still high. So at this point, we agreed that we will give this component to other patients who are bleeding in hospital outside trauma. And at this point, COVID hit, and we were not able to implement this because all the research resources, at least in the UK, were pooled towards COVID response. So we won't know what the impact is, but we have done a model. And if we were to implement that in the hospital, the wastage would have dropped to less than 5%. This is the clinical outcome data of the 3 arms. As you can see, red cell only arm, the red cell and thawed plasma or lyoplasma, and then the red cell and plasma component in one bag arm. And what I would like to draw attention to is time from injury to hospital arrival. As expected, the time to arrival to hospital was slightly longer outside London versus London. But the good thing was that for the 2 arms, for London Air Ambulance, they were quite similar. So the data demonstrate that we are looking at the same patients. And second, London had more penetrating injury than sites who were outside London, who had more blunt injury. And this data has been published and is free. Actually, you can access the paper. You don't have to pay. This is, I haven't included other information, but this is the adjusted mortality. And we looked at the association of the 2 arms with mortality. And the first thing I want to say is that indeed there were strong signals that if you give red cell and plasma, any forms of plasma, be that through thawed plasma, lyoplast, or RCP component, indeed, the 24-hour mortality was better than if you give red cell only transfusion. Now, if you look at the 95% confidence for the RBC plus P arm, it has crossed the one, so it was not significant. And there was a reason for that, because we went on to look at the interaction in the model between blunt and penetrating injury. And what we saw, to our surprise, that the effect with better outcome for red cell and plasma was due to, it was mainly in patients who had penetrating injury. We did not see this effect in patients who had blunt injury. And this is against what the Pampa trial has shown, and I think the Cryostat 2 trial also. So we don't understand what this means, and we do need to be very careful because this was still an observational study, but this was the data. There was no difference in 30-day mortality with regards to the association of these arms. So I'll move on to practical advantages. This is work done by Harriet Tucker, who was the other PhD student. She looked at recording 3 different teams who were experienced in delivering blood transfusion in pre-hospital setting. And she compared the 3 different arms, as you can see in red. One was giving 2 RCP unit, which was what London was doing. The second arm was 2 RBC plus 2 thawed plasma. And the third arm was 2 RBC plus 2 lyoplast. And they were all intervention that we were giving in England. And what Harriet went on to look at is these outcomes that you see on your right-hand side. Flow time, which was a time that was spent the moment you decided this patient needs blood transfusion to the moment when you completed administering that transfusion. And then the touch time, how much time you spend touching the component, etc. Number of steps, number of people, and number of components needed to complete the whole transfusion once the decision was made. And here are the results of the main outcomes. And you can see that when you give a combined component, indeed, it was superior with regards to time, number of resources, people you need, etc. But for me, the most surprising one was that giving 2 units of red cell and 2 lyoplast took 3 times longer than giving a combined component. And I don't know about here or in other countries, but lyoplast is more expensive than thawed plasma for us. So it's worth thinking about this data. What about the development of the new filters? I'm not sharing all the work that we've done because we did a very extensive laboratory work on that to look at the quality of the component. But what I would like to share with you is the platelet count, because we all understand what that is. And here are the results. So over time, even when you use a new filters that spare the platelet, your platelet count will go down. And you can see by day 21, they reach 50% of the baseline. So you've got to be aware that the whole blood you're getting doesn't have all the platelets that you have on the day 1. And also you need to be aware that no blood service will be able to supply you with fresh whole blood, i.e. 24-hour shelf life. So you do need to look at the risks and benefit of getting a longer shelf life of whole blood. Well, what about the design of the trial? So we wanted to look at the evidence. So we did a few systematic review, but I'll only share 4 of them with you. The first one was to look at what is the evidence that whole blood is better than standard of care in trauma patients who are bleeding. And this is work led by Rose Davenport, showing that there was absolutely no evidence. There was, at that time when we did the review, there was only 1 randomized control trial in US who had compared whole blood. And even that trial did not use a whole blood that we are talking about. They used more a modified whole blood. Second, we looked at outcome measures that are used in trauma studies that evaluate blood transfusion as an intervention. And even for mortality, I can tell you, it was defined in 30 different ways. I mean, how can you get that wrong? So there's absolutely no standardization with regards to outcomes that we should measure in these trials. The other review we did is to look at if we were to give you red cell and plasma component in one bag or whole blood, we as a blood service need to define what is the safe anti-A and anti-B titer that we can give you that does not cause any harm to the patients who are non-group O. And this is a piece of work done by Josephine. And to our surprise, this has never been done. But we were able to show that at least what we were using in the UK were within the safe limit. And that's what we will continue for the whole blood. And the last one is, as I showed you, if you were to give whole blood only to one group of patients in any country, I can guarantee you, you will end up wasting it. Because we use it in London, and London is the biggest trauma center for us in England. And if they had such a high wastage, all other sites will have even higher wastage. So we looked at, okay, we do need to give this component to other patients in order to keep the wastage down. So we looked at the evidence of use of whole blood outside trauma. And I think I was very impressed with some of the data. They were mainly in cardiac surgery, and there were actually signals that giving whole blood was better than giving component. But please don't tell any cardiac surgeons because they'll come on my door. And we just need to finish the trauma first, and then we can move to them. And then the last part we did was a survey. So this was led by Jason Smith and Ed Barnett. They surveyed all the pre-hospital services in England with regards to what are you doing now? Are you giving blood? Do you want us to introduce whole blood? And how would you like the component to be introduced? And the summary of this data shows that at the point when we did the survey, 90% of the services were already giving blood on board. So if you want to do any trial, you need to bear that in mind. So people have moved to a different stage, and you need to take that into account when you design the trial. And second, I think 80% of the services said that we would like to have whole blood, but we would also like to have good evidence. So that was a very strong message to us. So I cannot carry on without mentioning the refill trial, because also time was just as we were designing the next trial, refill trial was published. This is a UK study in pre-hospital setting. I personally think was a good study. It's just that we had moved on with it and we didn't support it as much as we should have supported it. But it looked at comparing blood transfusion through red cell and lyoplast versus cell line resuscitation in pre-hospital setting. And here are the primary outcome, which was composite of episode mortality or failure to clear lactate. And there was no difference. And it was published and reported as a negative trial. But if you look on, I think it's table 3 in that publication, at the 3-hour mortality, there was 7% absolute difference in mortality in the blood transfusion arm. It missed the significance because the study was underpowered. But had it reached the number that it needed, maybe 600 patients, you would have seen that difference. And I have contacted the CI of the refill trial because he's also part of the SWIFT trial, and asked him what was the 24-hour mortality in that trial. They were not supposed to put that out because it wasn't pre-specified in the protocol, which drives you nuts. You think you collect all this data and we can't publish them. But the 24-hour mortality was exactly the same as 3-hour mortality. Now, if I put it up to you guys, would you take a component that has 7% reduction in mortality at 24 hours forward in your clinical care? Raise your hand up if you say, yes, I would be very happy with that. Well, I would too, yeah. So it's just also how we report trials is very important. So everybody was saying, oh, why are you doing this trial? We need to stop giving blood to pre-hospital team. Why are we supporting them? Why are we pushing them to another level? But it's wrong. I think even refill trial, be that it took 6 years to complete, it did show some evidence that giving blood is better than giving crystalloid. So before we designed the SWIFT trial, this is where we were. We had evaluated the red cell and plasma component. We were able to also look at the new filters. We showed that if you give a component for one group of patients, the wastage is going to be high. There are logistical benefits to giving combined component in pre-hospital setting versus separate component. When you compare RCP arm versus red cell and thawdam, which I didn't share with you, there was no difference in outcome. So that's very reassuring for us. So whatever the SWIFT trial shows, if it shows that whole blood is not beneficial, I have promised the air ambulances that you will have RCP in one bag because of the logistical benefits. The clinical outcome for whole blood is absolutely non-existent, even though other countries have implemented this. And clinicians wanted us to produce high quality data before we implement whole blood. So this moves me very nicely to the SWIFT trial, which is a randomized control trial of pre-hospital whole blood transfusion versus standard of care in patients with life-threatening bleeding. Our primary research question will look to answer if pre-hospital whole blood transfusion is superior to standard of care in reducing composite of mortality or massive transfusion at 24 hours. I was very specific that this needs to be a superiority trial. We didn't want a non-inferiority trial because you can have the RCP component as far as I'm concerned, because for us to introduce whole blood, there will be so many changes we would need to make in the manufacturing unit that we do need to look at, is this cost-effective way of removing this important resource for other patients. And the secondary outcome is the usual cocktail that you will have in any trials. But what I want to put out or sort of pull out of the secondary outcome is the health economic evaluation that we will do. And the second one, we will also look at the implementation study. The implementation studies tend to happen usually after your phase 3 trial. So we want to look at what are the hurdles that we would need to overcome to implement whole blood in the whole country, should the result of the trial show it to be superior. This is the inclusion criteria, is a pragmatic trial. And like we did with RCP, we told services to carry on doing what they normally do. We did check their criteria for transfusing blood. Well, guess what? They were all the same because we like to copy each other. And the exclusion criteria are very simple. If you cannot give blood through intravenous or through your bones, then you can't recruit the patient. And second, if the patient has already told you that they don't want to get blood, then we would need to respect their wishes. And this is the trial design. What we've done is we've moved all the research activities away from the emergency services. So the randomization happens in the laboratory, in the transfusion laboratories. So when the team receives the boxes, they don't know what's in the box. And we have weighed the boxes for the intervention and the standard of care arm to make sure that they don't weigh differently, because you guys are quite smart. But the moment you open that box, that patient is randomized, so you cannot cheat. And people know that. So we try to make it as robust as possible. And patient in traumatic cardiac arrest will be treated separately. They will not be included in the main analysis because we know their outcome is different. And we saw in the previous study that 20 to 25% of patients you give blood to are in cardiac arrest. And don't get me started here with the London Air Ambulances. Why they're giving blood to their patients? Anyhow. And this is a number of patients we're looking at, just under 850 patients to randomize. These are the 10 air ambulances in England that are taking part in the trial. None of them are currently randomizing, and the last one is MAGPAS, is due to come at the end of February. And we've just been working with international sites. Canada and New Zealand will also start recruitment in March. The other thing I would like to highlight is the funding model for this trial is not funded by usual funders for research, but is funded by the very organization that would like to really get the answer to this question. So the 10 charities you're seeing here are co-funding equally the trial with the National Blood Service, and the Ministry of Defence in the UK has also contributed to part of that funding, which is not as high as the other two partners. So it really shows that if you work with everyone, people would be very happy to support you, even financially. Here is a site update. As I said, 9 sites are currently recruiting. And I want to highlight here the number of sites we had to work in 9 months, we've set up 9 sites, and it's heroic, honestly. 45 sites we had to work with, and 236 people we had to be that are directly involved with delivering this trial, because you have your transfusion laboratory, the research team who collecting the data, your pre-hospital team, and your trauma services. So it's a huge amount of work from the clinical trial unit to get this trial up and running. And we've learned so much about how you set up trial. And we've had so much enthusiasm. A lot of other services have approached us to want to take part in the trial, and we just can't support them because we need to be able to deliver the component for the sites. And here is some preliminary data from the January trial management group, where we are with recruitment. As you can see, London was the first to start. That's why, because I'm in London, so I had to make sure, I had to show by example that I support this study. So just under 50% are from London, and the rest are from the other sites. And my last 2 slides are mainly acknowledgement. These are the people and the organization that supported the first part of the study, the red cell and plasma study, and the funders at the bottom, and of course the SWIFT trial, who is now completing the program. So thank you very much for your attention.